Thank you, Mr. President. I rise this afternoon to talk about a huge problem that's affecting, I'm pretty sure, every one of our states. I know it's certainly affecting my state in a very, very serious way. And this is the abuse of opioid painkillers, which often leads to the abuse of heroin and leads to overdose and is leading to deaths. Mr. President, this is just wreaking havoc all across Pennsylvania. It's affecting every geographic part of the state. It's in urban areas, suburban, rural areas. It's every demographic group, every age group, and the scale of the problem is shocking. The increase in the number of people that are overdosing, that are becoming addicted is really, really disturbing. I began hearing about this immediately when I became senator in 2011, and this problem, frankly, is getting worse. Recently, I became the chairman of the Senate Finance Subcommittee on Health, and that's given me an opportunity to delve into this ever more deeply. We've had a series of hearings across Pennsylvania to get as much expertise as possible so that we can learn about what's causing this, how do we deal with it. And there's three areas that have come to my attention, three directions that I think the federal government can pursue to help deal with this very complex, very widespread problem of opioid addiction. One is certainly to improve the access to and the quality of treatment for people who are addicted. There's no question that this is a very, very difficult disease to treat. There's so much of it we don't understand. We don't understand what predisposes someone to be more likely to develop an addiction. We don't understand the genetic implications. We know that there's behavioral issues. We just don't understand as much as we need to know about it. We do know that often there are underlying mental health issues that contribute to this problem. But whatever these causes are, we need to learn more so that we can treat them better and prevent them better. And we need to treat the people who are currently finding themselves in the very, very difficult situation of facing addiction. So I would say that's category number one, Mr. President. But there's another thing that we can do here in the federal government, and that is take steps to reduce the diversion of these powerful prescription narcotics to the black markets. In fact, prescription opioids are available on the street for a price. There's a market for them, and they contribute to the addiction problem that we have. They don't get there because a burglar broke in and stole them from a pharmacy. That's not the typical way that these narcotics get to the street. They get there because someone prescribed it and a prescription was filled. And so we need to look at ways to reduce that phenomenon. I introduced legislation with Senator Casey, my Pennsylvania colleague, also with Senators Portman, Senator Brown, and Senator Kane. And that legislation was designed to do just that, to reduce the frequency, the occurrence of prescription opioids finding their way into the black market. And the way our bill works is it provides to Medicare a tool that Medicaid and private insurers have long had. And that's a tool called lock-in. And what it refers to is that when an insurer, in the case of our legislation, it would be Medicare, when the insurer discovers that a patient is doctor shopping, systematically going to multiple doctors, getting multiple prescriptions for opioids, then filling them at multiple pharmacies and ending up with a commercial scale quantity, what our legislation would do, it would allow Medicare to lock that patient into a single prescriber and a single pharmacy. So any person with a legitimate need can get that need met, but we could put an end to some of these very large quantities reaching the black market. So good news is our legislation was offered as an amendment. Senator Casey and I offered it as an amendment to the CARA legislation a few weeks ago. It was adopted by the Senate. And of course, the underlying CARA legislation was passed by the Senate. So I'm hoping that the House will take this up, will pass this, and we'll get it to the President, who I'm confident will sign it. That would be a good step in the right direction. The third category of action that I think we need to consider is steps that would reduce overprescribing. Overprescribing in the first place. One of the things that I've learned from the many hearings I've had across Pennsylvania is doctors who have told me and described for me a culture within medicine in recent decades which has put so much emphasis on eliminating all pain that doctors are tending to prescribe these opioids in far greater quantities than would have been imagined certainly a couple of decades ago. So that's an important piece. I've raised questions about whether it is appropriate to use opioids to treat long-term chronic pain as opposed to short-term acute pain. That's another area that we ought to be raising questions for healthcare professionals to help us understand and answer. But there's yet another way, Mr. President, that I think we can address here in the Senate, and that is an unintended consequence of Obamacare, a provision in Obamacare that I think is encouraging doctors to overprescribe opioids in the hospital setting, and that's what I want to talk about today. So a little background on this. Obamacare created a system that provides financial rewards to hospitals that perform well on certain outcomes, like reducing readmissions and hospital-acquired infections, for instance. And if you do badly in those areas, then you are penalized. You get lower reimbursements. So it's a financial set of incentives to get better outcomes. And those two examples that I just mentioned, readmissions and hospital-acquired infections, those are objective, those are measurable, those are quantifiable, and there's little doubt that we want to see less of those things. You can argue that it makes sense to have financial incentives that deal with that. But Obamacare also links reimbursement for hospitals to a much more subjective outcome, separate and apart from the ones I just mentioned, and that is patient satisfaction as defined by the government. Specifically, the federal government mandates that hospitals survey their patients about their stay at a hospital using a form known as the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAHPS. It's known as HCAHPS. That's the survey that hospitals are required by Obamacare to administer to their patients. And hospitals that have a higher score on this survey get more money, and hospitals that have lower scores on the survey get less money. There's roughly $500 million swing at state nationally across the country based on these personal patient satisfaction scores alone. So it's not just that the government is saying that these scores are important, the government is making it financially important to these hospitals. Well, this raises a question, and the question is the hospital score on some bureaucrat's test always in the patient's best interest? It's not clear to me that it always is. Now, there's no doubt that hospitals, physicians, nurses, healthcare providers generally, of course they want to have satisfied patients. We all do, right? We want to be a satisfied patient when we go to see a doctor or go to the hospital. It's obviously a good thing if a patient has as good an experience as possible. But it's specifically the survey questions on pain management per se that are raising a lot of red flags, not just with me, but with healthcare professionals, with people who have been studying this. It's a recent Time magazine article, and we've got a little excerpt here. And the title was How Obamacare is Fueling America's Opioid Epidemic. And this article is a lengthy investigation into the unintended, but as I said, predictable consequences of this Obamacare-created HCAHPS survey, and specifically the questions in the survey that relate to pain management and the prescriptions of opioids. Here are the questions from the survey. One of the questions is, during this hospital stay, did you need medicine for pain? Second question, during this hospital stay, how often was your pain well controlled? And finally, during this hospital stay, how often did the hospital staff do everything they could to help you with your pain? These are the questions that patients respond to, and they contribute to the overall score on the test, and the score on the test determines in part the level at which the hospital is reimbursed by Medicare. There's a very powerful financial incentive for hospitals to make sure that patients are answering these questions in a way that will get the desired response from CMS, from Medicare. They're graded on these questions. So it's a big incentive. And when you tie the measurement of these kinds of questions to reimbursement, you are very likely to get changes in behavior. And in fact, that seems to be what's happening. You know, I think we need to ask ourselves whether we're striking the appropriate balance here when 27,000 people are dying from heroin and prescription painkiller overdoses. And many of the people who are dying from heroin overdoses began with prescription opioids. And they moved on to heroin when they discovered that it was cheaper and more available than the prescription opioid that they got addicted to in the first place. So there's increasing evidence now that physicians and hospitals are in fact responding to these incentives, these financial incentives, and they're responding by prescribing more opioids. Dr. Nick Sawyer, a health policy fellow at the UC Davis Department of Emergency Medicine, told Time magazine, and I quote, "The government is telling us we need to make sure a patient's pain is under control. It's hard to make them happy without a narcotic. This policy is leading to ongoing opioid abuse," end quote. It's a survey by a South Carolina Medical Association found almost half of over 150 doctors responding. These doctors reported themselves that they were prescribing inappropriate narcotic pain medication because of the patient satisfaction questions. One doctor wrote that drug seekers, quote, "are well aware of the patient satisfaction scores and how they can use these threats and complaints to obtain narcotics." Here's two examples from a story titled "Patient Satisfaction is Overrated," published by the Pennsylvania Academy of Family Physicians, from Press Ganey, a company that administers patient satisfaction surveys that often includes these HCAP questions. One doctor reported that he had to give Dilaudid, and that's a powerful prescription opioid, for minor pain because his score on this test was too low the previous month. An emergency room doctor with poor survey scores started offering hydrocodone goodie bags to discharge patients to improve his ratings. Now, as I said, I've had multiple field hearings across Pennsylvania to hear firsthand from healthcare providers, recovering addicts, law enforcement, people who are dealing with this epidemic in a variety of ways. One of our witnesses in Pittsburgh last October was Dr. Jack Cabezi. He's the system director of Allegheny Health Network's Division of Pain Medicine, and he testified, and I quote, "Physicians who have compensation or employment tied to patient satisfaction scores may feel pressured to prescribe opioids in response to patient pain complaints." Another ER doctor told my office how his hospital administrator informed him that the ER patient satisfaction scores were in the 50th percentile, or average, and that he should find a way to get them higher, or, quote, "I'll find someone who can," end quote. This is a big concern. This is a range of evidence that doctors and hospitals have been changing their prescribing habits in response to these pain questions. Now, let me be clear about one thing. None of us wants to see anyone needlessly suffer. None of us wants to themselves go through pain that's unnecessary. None of us want to see a loved one or anybody experiencing pain if it could be appropriately managed. And for the terminally ill, then of course it makes sense to do everything possible to make those folks as comfortable as they can in their final days. But what I'm asking is, are we appropriately weighing the risks and the benefits here? Sure, there is a benefit to complete and immediate elimination of all pain that a powerful narcotic can temporarily provide. But we know that there is also a risk of addiction to that narcotic. That risk is very significant. It's increased exponentially, and that addiction is incredibly dangerous because it can spiral out of control, lead to even heroin abuse, addiction, and death. Have we gone too far in creating an expectation that the result for every patient must be zero pain? Or are there some circumstances in which it's better to treat pain as best we can with non-narcotics, other ways? There are other medicines, there are other treatments, there's physical therapy, there are other ways to diminish pain. It may not be 100% effective all the time, but if it's temporary and it has zero risk of opioid addiction, then maybe we ought to be considering that a little more frequently. So Mr. President, let me say, this is definitely a complicated issue. There are many factors contributing to the heroin epidemic, the opioid epidemic, but it's increasingly looking like one of the contributing factors at some level is the financial incentives created by this aspect of Obamacare, this particular questionnaire that focuses significantly on complete elimination of pain. And I think we need to ask ourselves whether this is appropriate. Last week, the group Physicians for Responsible Opioid Prescribing sent a petition signed by more than 60 nonprofit groups and medical experts, including Pennsylvania's Department of Health Secretary Karen Murphy. They sent the letter to CMS calling for the removal of the pain questions from the HCAP survey. Now, that's one approach. Senator Johnson from Wisconsin, he's introduced a bipartisan bill that has a lot of merit. His bill is called the Promoting Responsible Opioid Prescribing Act. What his bill does is it removes the results of the pain questions from Medicare's calculations of reimbursement. So the questions would still be asked. We would still learn about how patients feel about the extent to which their pain was managed, but it wouldn't affect the hospital's reimbursement. I think there's a lot of merit to that proposal. And again, Mr. President, it's because we are in the midst of a deadly crisis. It is killing people every day. The impact of opioid addiction and heroin addiction and overdose on a family is so devastating. I can only imagine the grief, but I know people who have been through the grief of losing a child, losing a loved one to this terrible scourge. And that's why I'm down here on the Senate floor today. That's why I want to continue to focus on this. I think there are many things that we need to consider, but one of them is decoupling the results of these pain questions from the level of reimbursement, because the evidence is starting to mount that the financial tie is creating incentives to change behavior. So I hope that we will, as a body, we'll address this issue seriously, because there's a lot that needs to be done on this, Mr. President, and I appreciate the recognition, and I yield the floor.